Good afternoon, members of Symposium on Global Cancer Research and guests. I want to thank the Scientific Program Committee for selecting our abstract for an oral presentation. On behalf of my co-investigators, I will present the abstract Causes of Treatment Failure based on regimen for Wilms tumor in AHOPCA countries. The Central American Association of Pediatric Hematology Oncology, AHOPCA, is a collaborative group of 7 Central American and Caribbean low-income countries. AHOPCA began treating patients with cancer in 1999. The specific Wilms protocol started in 2000 and it had been analyzed by eras. This report from the most recent era, 2012 to 2015, focuses on causes of treatment failure. In this last era, 182 patients, evaluable patients, were diagnosed with unilateral Wilms tumor. All but 13 cases had histologically confirmed Wilms tumor diagnosis. Patients were staged with abdominal and pelvic ultrasound and chest X-ray or computer tomography and surgical findings. Therapy was adopted from the National Wilms Tumor Study 5, including surgery, chemotherapy, and radiotherapy. The regimen are described here according to stage and histology. Patients with large abdominal masses or in stage 4 with high tumor burden or severe malnutrition receive preoperative chemotherapy. This decision not only depended on tumor extension, but also on the underlying clinical condition patients. Stage and therapy assignment were discussed at weekly internet conferences. Decision generally favored intensive therapy that included 2 drugs and the median of weeks of treatment with 8 to reach an adequate rate of tumor reduction previous to surgery. Treatment failure was defined as abandonment or refuse of therapy, recurrence of progressive disease, and death, early death and toxic death. The gender distribution was balanced, with 89 patients being male, 49%. The median age at diagnosis was 3.5 years and the range 0 to 16 years. The age distribution was less than 2 years of age, 41 patients, 2 to 5 years, 98 patients, and more than 5 years of age, 43 patients. The AHOPCA countries don't have central review of histology, and probably the number of cases with unfavorable histology was overdiagnosed. The cases with favorable histology were 86%, and with unfavorable histology, 14%. Unfavorable histology, including focal and diffuse anaplasia, 13 cases were unclassified. Related to tumor stage distribution, 4% of patients were in stage 1, 12 in stage 2, 64 stage 3, and 20% stage 4. 84% of patients in AHOPCA are in advanced disease. Nutritional status was evaluated with an anthropometry, which is a more sensitive indicator of malnutrition than any measure based on weight and height. Although mid-upper arm circumferences and triceps skin form are independent of ethnicity and unlike weight, are not influenced by large tumor masses. We have 46 patients evaluated with all the anthropometric assessment. 39% of patients were depleted and 20% were classified as severely depleted. Therapeutic failures were 3 times more common in nutritional depleted children in relation to adequate, reducing the 3 years event-free survival from 82% to 53% in depleted children. The causes of treatment failure were recurrent or progressive disease 15%, abandonment 10%, and death 3%. Early death associated to advanced disease and severe complications is most common in children younger than 5 years of age and toxic deaths. The abandonment-sensitive 3 years event-free survival was 68% for patients as a whole, and abandonment-sensitive 3 years overall survival was 71%. The outcome by ERAS has improved due to a significant reduction of recurrence and abandonment, where progressive disease and early death remain stable. Since inception of protocol, the Wilms Tumor Group has been refining their strategy of chemotherapy, improving the outcome of children who commonly present with large masses and are in poor clinical conditions, and has been working towards prevention of abandonment, dropping the rate from 21% to 10%. All these efforts have improved the event-free survival from 52% in the first era to 68% in the last era. In conclusion, multicenter protocol-driven therapy tailored to fit local needs is feasible in patients with Wilms tumor in this setting. The outcome in patients who experience therapeutic failures is bad. Only 32% of them were possible to save. Abandonment and late diagnosis remain a challenge, as do early and toxic deaths due to advanced presentation in fragile children. Finally, I want to thank all those who work to make this result possible and the institutions who have a long-term commitment with our programs. Thank you very much.
And now we have a couple of minutes for questions.
Yes.
What were the main reasons? Thanks. What were the main reasons why patients abandoned treatment, and how did you manage to drive that statistic down?
I think I posted here about the abandonment in the AHOPCA region, but are many problems. Maybe the most important is the economic factor, and also education on families, and I think this is the more important. Another? Yes?
Yeah, I'm sorry. In your context, do you consider the fragility, the nutritional problems, matter of food insecurity or disease severity? And in either case, have your clinicians considered any kind of intervention, nutritional intervention or something of that sort to work on this?
I think both are important. The majority of patients are inadequate for nutritional status, but also we have the more of patients in advanced stages, And I think both are very important and impact the diagnosis. We have a specific problem since started the unit in Guatemala 16 years ago to evaluate the nutritional status of children, and all of them are supported with specific things to improve the nutritional status for support the therapies.